My name is Julianne. I'm a Marywood University nursing student, and today I'm going to be performing an abdominal assessment on you. Is that okay?
Yes.
All right, so after introducing myself to the patient, I would perform hand hygiene and don gloves. So before I begin the assessment, I just want to ask you a few questions about just your history and general health, about your pertaining to your abdomen and just your body, okay?
Okay.
So, when was your last bowel movement?
Yesterday.
Okay, have you had any diarrhea or vomiting that's abnormal?
Nope.
No. Are you urinating okay?
Yes.
Yeah. Have you traveled like out of the country
No.
lately? No. Okay, are you constipated?
No.
No. How many times a week do you say that you have a bowel movement?
About like 5 to 6.
Good. Alright, so do you have any abdominal pain whatsoever?
Nope.
No? Okay, so after asking my patient about just a little bit about his health and just his general health history, I can begin the assessment. So I'm going to ask you to lift up your shirt for me.
Sure.
Alright, thank you. So with this, I'm performing inspection, the first part of the abdominal assessment. I'm just inspecting the abdomen to ensure that there's no abnormal pulsations. I'm seeing that he's breathing symmetrically. There's no pulsations of the abdominal aorta. He's rounded, a rounded stomach, which is normal. That's normal, which is very normal. I'm just seeing that there's no abnormal masses that I can see from the naked eye without touching him or anything. The skin color is the same as the rest of his body, it seems. I'm not seeing any peristalsis waves, so everything looks pretty good. So the next part of the assessment is auscultation. We auscultate second in this type of assessment because we want to be able to hear the bowel sounds before we start palpating and percussing, because palpation tends to cause the bowel sounds to really start up, and so you don't want to have that. So with auscultation, I'm going to listen to each quadrant, beginning in the right lower quadrant and working clockwise around in each quadrant. I'm going to listen for bowel sounds with the diaphragm of my stethoscope. A normal bowel sounds will be 5 to 30 clicks per minute. They're irregular. There's no real sound. It's just the clicks and gurgles and just multiple sounds per 5 to 30 per minute. If there was lower than that, it would be hypoactive, and if there was more than that, it would be hyperactive bowel sounds. With this, I'm going to begin auscultating, and if I do not hear anything in either one of the quadrants, you should hear it in the right lower quadrant if you when you're beginning, but if you don't, you would auscultate for 5 minutes before deciphering whether or not the patient has a paralytic ileus. So I'm just going to begin by auscultating in the right lower quadrant with the diaphragm. So I'm hearing those clicks. I've already heard a bunch of clicks in the right lower quadrant indicating that he has a normal bowel. I'm in the left upper quadrant now, still working clockwise, still hearing those bowel sounds. They're a little less in this quadrant, but I still do hear them. And then in the left lower, I'm still hearing those clicks and gurgles, that irregular sound of the bowel. Alright, so now that I did hear a normal bowel, 5 to 30 clicks per minute, I'm going to begin auscultating for vascular sound, which includes the abdominal aorta, the renal arteries, the iliac arteries, as well as the femoral arteries. With this, I'm going to use the bell of my stethoscope to to listen to these. I'm in these arteries, I'm listening for bruits, which would be indicative of an obstruction of an artery. These bruits are usually caused by like a buildup of plaque, so that was important to listen for. So I'm going to begin by auscultating in the abdominal aorta, which is below the xiphoid process and above the navel. So I'm just going to listen with the bell of my stethoscope for any bruits or abnormalities. I don't hear any blowing sounds that I would hear, which would indicate a bruit. So after the abdominal aorta, I'm going to move down to either side of the umbilicus where the femoral arteries are, and I'm going to listen for the same thing, the bruits. And I'm going to go on the other side, still listening to those femoral arteries. I'm going to move down a little bit and listen to the iliac arteries for the same thing. And then I'm going to move down to the femoral arteries. Okay. So auscultation was normal. As I said before, the bowel is sounding great, 5 to 30 clicks per minute, not hypoactive, not hyperactive, definitely no paralytic ileus. And for the vascular sounds, the abdominal aorta, the femoral arteries, the iliac arteries, femoral, renal, and iliac arteries, and the abdominal aorta, I do not hear any bruits. Everything is clear. There's no swishing sound that we would be concerned of. So after auscultation, I'm going to begin percussion. With percussion, tympany is normal over an air-filled abdomen, whereas dullness is normal over an organ. So I'm just going to begin percussing in each of the quadrants to listen for tympany. Still working clockwise, starting in the right lower quadrant. You're doing okay?
Yes.
All right, so that was tympany was heard in air-filled abdomen, which is normal. Then the next thing I'm going to do is I'm going to assess for the size of the liver, which is also going to be done during percussion. So for this, I'm going to begin at the right lower quadrant, and I'm going to work my way upwards until I can hear the change from tympany to dullness, indicating that that would be where the liver is. So with that, a liver is usually 3 to 7 centimeters, and if it was discovered that it was over 3 to 7 centimeters, did you hear that? What is that? What is it?
Downstairs.
Okay, sorry. 3 to 7 centimeters. If it was over 3 to 7 centimeters, it would be indicative of hepatomegaly, which is enlarged liver. So the liver also tends to go in between, like up against, like higher against the ribs. So I'm going to still percuss in between each intercostal space to still hear that liver, or feel that liver. That change from the dullness to, all right, so right about there. That change right there. From tympany to dullness, and I'm going to do the same thing with the spleen, which is going to be on the left side, okay? And I'm just going to listen for the change from tympany to dullness. Does that hurt?
No.
No? Okay. It's right about there. I'm still going in the intercostal spaces. So again with the spleen, if it was enlarged which it is not. Upon percussion, I did not find an enlarged liver, which is hepatomegaly, or an enlarged spleen, which would be splenomegaly. So with that, listening for the change from tympany to dullness and evaluating the size of the liver and the spleen in the right quadrant and then the left quadrant. After assessing for the change from tympany to dullness and evaluating the size of the liver and the spleen in the left quadrants and the right quadrants, I'm going to begin palpation. So with palpation, I'm going to begin with light palpation, okay? I'm going to palpate in each of the 4 quadrants, going in a circular motion, just to get the patient not ready, but used to this feeling before I go into deep palpation to be able to feel the organs. So I'm now going to deeply palpate your abdomen. With deep palpation, I'm going to feel for the size of different organs. Just feel for the organs. Just let me know if I'm causing too much pain, okay?
Mm.
Okay, you okay?
Yes.
Okay. You okay?
Yes.
Yeah? Okay. Alright, so with deep palpation, that's just me being able to really like feel the organs and really just a part of the assessment. So the next thing I'm going to be doing is after the assessment, I'm just going to be performing like different tests, which I would perform specifically if you came in with abdominal pain or just different worries. So these tests will indicate like cholecystitis or an inflamed gallbladder, appendicitis or a perforated appendix, or peritoneum or peritonitis, which is like inflammation of the peritoneum. So the first test I'm going to perform is I'm just going to hook my hands, okay, on the right side of you, and I'm going to just ask you to take a deep breath, okay? With this is liver palpation hooking, so I'm just going to assess for really the liver here. It's I shouldn't be able to palpate it on this, and you should not have any pain. So I'm just going to ask you to take a deep breath after I do that. Take a deep breath. All right, so my hands moved inward and upward. Liver was non-palpable, so that's a normal sign. So the next thing, I'm going to do the same thing, and I'm going to ask you if you have any pain, all right?
Okay.
So this is, rather than testing for the gallbladder now, I'm going to be testing for rather than testing for the liver, I'm going to be testing for the gallbladder. So with this, if you had any pain, did you have any pain prior?
No.
No, well, I'm just going to do it one more time just to ensure, okay? Actually, can you move down this way? I'm so sorry. Okay. And I'm just going to stand on this side of you, and I'm just going to do the same thing. Okay, just going to go upper costal margin of his ribs, and I'm going to hook my fingers, and I'm going to ask you to take a deep breath and let go. Did you have any pain whatsoever?
No.
No? Okay. All right. So that would be indicative of an inflamed gallbladder or cholecystitis, okay? So the next test I'm going to do, next few tests are going to use your legs, and I'm still going to do a little bit more testing on your abdomen, okay?
Okay.
All right, so the next one I'm going to do is going to be indicative of appendicitis. It's the rebound or Rosbank's test. I'm going to deeply palpate or push on the left lower quadrant, okay? And I'm going to ask you if any pain, all right? All right, just let me know if you have any pain when I release the... Did you have any pain?
No.
No? All right, so if the patient had pain, it would be indicative of appendicitis. The next test I'm gonna perform is the psoas sign. So I'm just gonna ask you to lift your leg for me. Thank you. Do you have any pain?
Nope.
No? All right, can you do the same thing against resistance for me?
Okay.
Same leg? Any pain?
Oh.
No? Okay, so that's psoas sign. And if the patient had any pain, that's also indicative of appendicitis. All right, the next test is going to be called the obturator sign. With the obturator sign, I'm going to lift his knee, supporting his ankle and his knee at the same time, and I'm going to internally rotate and externally rotate. This is also indicative of appendicitis. All right? Just let me know if you have any pain. And I'm going to internally rotate your leg, and we're going to externally. Is there any pain?
Nope.
Okay. All right. So that, I believe, is the whole abdominal assessment.
Okay.
Okay?
Thank you.
Thank you.